Ladies and gentlemen, I'm Xiaohua from Fudan University. Fudan University is one of the top universities in China, located in Shanghai city, a very beautiful city. Today, I'm very glad to share the health system reform information in China with you. And actually, I prepare a slide to introduce myself, but Randy has conducted. To be frankly, my research interest is very general, but now I narrow the research field to the financing, insurance, and health economics evaluation. And I'm also interested in the environmental health economics. And today I will give some broad introduction of the health reform in China. Firstly, I will give the why reform, introduce the reason of the health reform and the health system in China, and then go to the framework of the reform and how to reform and some important plans of the reform. And the third one will focus on pay more attention on the public health insurance reform, and at last is the challenges and conclusion. And before to introduce why the government in China launched the reform, I'd like to say something about the health system in China, because the health system in China is much different to the United States, and it is also much different to most of the developed countries. Most of the health care service delivered by the hospital instead of the hospital and the clinics. It means that if you want to go to see a doctor, go to see outpatient service, you should go to hospitals. And there are three tiers of hospitals. In urban area, the first tier is the community center. We call it the community health hospital or community health center, provide the primary health care service. And the third one is the secondary hospitals. It is a center of the district, health center district. And the third one is the tertiary hospitals. In rural area, the three tiers means village, township, and counties. And I think important thing in China in the delivery system is the state-owned hospitals' role. The state-owned hospitals are the main providers for health care. More than 70% of the health care provided by the state-owned hospitals, especially in the inpatient service. However, the state-owned hospitals run like the for-profit models because they can't get enough subsidy from the government. The government subsidy to the state-owned hospitals is less than 10% of the hospital's revenue. So it means that hospitals should earn more money through the healthcare provisions. And other thing I'd like to say is organization of the governance. So, the healthcare delivery system is administered by the Ministry of Health. However, the public health insurance system managed by the Ministry of Human Resources and Social Security. I don't think there's a very clear function between these two ministries. So these two ministries are always argument to some rights. And now as we go to why reform. With the rapid economic growth in last 30 years, the healthcare system, the health status, and the equity of health isn't along with the growth of the economics. So more and more people feel that too difficult to see a doctor and too expensive to see a doctor after 2000. these two sentences are very, very, very popular in China. It is always to use as the problem to describe the health system problem. Actually, I think too difficult to see a doctor may be related to the accessibility, equity. However, too expensive to see a doctor will be related to financial risk protection. So this problem.
Okay. So if the hospital hospitals work like a for-profit center, when we say it's too difficult to see a doctor, that means there is likely low demand, right? And if there's no demand, I don't see how it would be too expensive. Should the prices come down? Are they working like for-profits or not?
Too difficult to see a doctor. For example, if you want to see a doctor, maybe you will wait a long time.
Right.
Yeah, and in some remote area, there are not enough ability to provide healthcare service, especially so the healthcare provision ability in rural area or in the remote area is lower. Then in that area, people is difficult to receive the healthcare service.
Right.
Yeah.
So is it not possible for a new person to say I can start a hospital, or only the state will? It's the only state-run hospitals. Nobody else can start a hospital, or the.
I think that although the hospital is state-owned, but the ability of the healthcare service provision is limited. So maybe the demand is higher, but
right.
the provision is low.
Okay.
Can't meet the demand.
They can't meet the demand.
Yeah. And also, these two problems, I think, is overlap. And then something happened. And now let me show some data of the health expenditure. This one is GDP, and the red line is the share of expenditure to GDP. It seems that in 2007, the health expenditure to GDP is lower than 5%, is not so higher. This one is health expenditure per capita in 2007. The health expenditure per capita went to about $115. However, it is much less than that of the United States. This one is
are these inflation adjusted?
Sorry?
These are inflation adjusted, yeah?
Sorry?
These are inflation adjusted figures. Are they in constant dollars, or they are just nominal?
Nominal.
Nominal.
Yes.
Okay.
And I think the health expenditure seems lower, or the share of the GDP seems lower. So why the people feel it's too expensive to see a doctor? It is maybe related to the out-of-pocket. The out-of-pocket in the health expenditure contribution is about 45%, means that about half of the health expenditure came from out-of-pocket. And the growth of the out-of-pocket is much higher than that of the government health expenditure growth, also higher than the GDP annual growth. So now it's health expenditure distribution. More than 55% people living in rural area. However, these rural area populations spend only about 23% of the health expenditure. And unfortunately, the health expenditure gap between the urban area and the rural area is enlarging. So it's enlarging. And now we will talk about the healthcare utilization. With the rapid economic growth, the healthcare utilization has reversed the trend. From 1993 to 2003, the outpatient visits in last 2 weeks in rural area decreased from 1.20 to 1.12. And also in the urban area, the healthcare utilization for the outpatient is also decreased from the 0.13 to 0.14. I think the healthcare utilization decrease may be related to the health insurance coverage decrease. From 1993 to 2003, the health insurance coverage in urban area decreased from the 73% to 50%. I can't find the data of the rural area in 1993. But if we calculate the health insurance coverage all over China in 2003, maybe they are about 60% of the people in China haven't any health insurance in 2007 or 3.
Well, what accounts for that decline from 73% down to 50%? Why did the coverage go down?
Yeah, coverage go down.
But why?
I think because with the economic development, the economic model transfer from the plan economics to plan to market. So the health security system is also changed. Before 2000, the health insurance is composed. We call it the labor health insurance and the government subsidy health insurance. And however, after 1980s, these two, or I think after 1990s, these two programs cancelled. So I think in the end of last century, there are no fixed public health insurance programs in China, either in urban area or in the rural area. So I will talk about how to establish the public health insurance after 2000. And based on the World Health Report in 2000, we can find that three indicators composed of the health system reform. One is health data, second is responsiveness, and the third one is financial risk protection. In 199 countries, the financial risk protection ranked 188 of China. So the Chinese financial risk protection is terrible based on the World Health Report. Why I selected this data? Because World Health Report 2000 is the only ranking system for the health system performance. And this one is a table from the report.
Dr. Ying, what is the definition of responsiveness? Responsiveness means the health systems response to the demand of health, and also including the provider's responsiveness. So to be frank, it will include some indicators from the consumer and from the provider satisfactions. To deal with this problem, the Chinese government launched the health reforms. The aim of the health reform is to increasing accessibility of basic health care, ensure population in China can get the health care they needed, and the second one is the decreasing financial risk on health care utilization. And there are 5 sentences in the framework of the
health reform. One is the universal health insurance coverage, and the second one is the basic public health system, and the third one is to set up the essential drug systems, and the fourth one is the healthcare delivery system to improve the capacity of the delivery. And the last one is reform on the public hospitals. Today we will talk about these three ones, and we will pay more attention on the public health insurance. And the central government divided 9 categories of the basic health service package, including the disease control, vaccination, disease surveillance, and so on. And also the central government, and this one is a figure of the 9 categories of public health service. And also the central government set up a package including 21 service, public health service. It means that all of the China population can access to these 21 public health service. It's a national level package. The government invests $2.5 per capita per year for covering these 21 public health service. However, this healthcare service can be adjusted in the local government based on the 21 service. For example, in Shanghai, Shanghai government published a basic public health service package including 42 service, and the government invests about $8 per capita per year for covering this service. And essential drug systems, the central government set up essential drug list contains about 300 drugs. And in the provincial levels, the local government can make some adjustment. For example, in Shanghai, the Shanghai essential drug list contains more than 500 drugs. So another thing to the essential drug system is the government said that the primary public hospitals can prescribe essential drug only. They can't prescribe other drugs. And there are also some regulations on the essential drug systems, including their producing and the distribution and the purchasing. The local government in the provincial levels defining producers through the bidding. And also the provincial level, the provincial government select some big distributors and contracting with them to provide drugs. And now let me go to the public health insurance. Now there are three public health insurance programs in China. 2 of them are in urban area. One is in rural area. The urban employee basic health insurance cover the employee and retired populations. And it is compulsory and launched in the end of last century. And the urban resident basic health insurance cover the unemployed, cover the housewife and the children. And it is voluntary. And all the population living in rural area should be covered by the new cooperative medical schemes. We call it the NCMH. It's also voluntary. Now it's the program process of the urban resident basic health insurance. This program developed in 2006, and through the pilot and the expanded pilot in 2007, this program was fully implemented all over China. And as to the NCMS, the program covers the rural area. It was developed in 2002 And through the pilot and extended pilot, it was fully implemented in 2007. So the reform process is very quickly. And now about 400 million population living in urban area have been covered by the public health insurance, including the urban employee health insurance and including the urban resident health insurance. And also in the rural area, more than 800 million population covered by the NCMS. And until 2009, there are only about 9% of the population in China haven't any public health insurance. And most of the Chinese people covered by the NCMS and others covered by the urban employee health insurance and urban resident health insurance. And some of the people without any public health insurance covered by the private health insurance. And now let's talk about some financing, or talk about we analyze the premium for the health insurance. The urban employee basic health insurance is a typical social health insurance program. It gets money based on the payroll tax. The province or the cities can adjust the payroll rate through the 8% to 14%. For example, in Shanghai, the payroll tax rate is 14%. And for the urban resident health insurance, the premium was about $16 per capita per year. And however, the government contributes more than 50% of the premiums.
Is it voluntary enrollment?
Yeah. And the individual only paid it about 44% of the premium. And for the NCMS, which covers people in rural area, the average premium is about $15. However, most of the premium came from the government, including the central government and including the local government.
You say $15.5 or $3.2 per month,
per year. Yeah, per year.
And the UE-BHI is 878 in comparison to that?
Sorry?
The example you have, is that the average amount of payroll tax contribution, or?
This one is the payroll tax. This one is the premium.
That's how much they pay.
Yeah.
It's the annual premium.
For the urban employee based health insurance, the money came from the employee and the employee.
Right.
And now we will analyze some challenges. I will talk about three kind of challenges. One is the fund collection. I think from one side to UE-BHI, which cover the employee, I think in some cities maybe the payroll tax rate is higher. For example, in Shanghai, the payroll tax rate reached about 14%. Think about of the Germany. You know, the social health insurance in Germany also finance about 14% of their payroll. However, the social health insurance in Germany cover not only the employee but also their families. And in Shanghai, based on the similar health insurance financing levels, the health insurance program cover only the employee, doesn't cover their families. So, and also the higher payroll rate will increase the burden of the enterprises. And in the other side, for the urban resident health insurance and the NCMS, I think the financing level seems lower. In some area, there are less than $10 premium per capita per year. And from the fund condition models, we can find that most of the money came from the general tax, and as to the urban employee health insurance, most of the money came from the social health insurance financing models. So I think the financing method or financing resource seems narrow, seems simple. And also the government investment varied across health insurance program and varied across regions. In some rich area, in some rich cities, government invest much more than some poor country, or there's some poor province or poor regions. The third one for the fund collection is for urban resident health insurance and for NCMS. The premium is a fixed amount. This premium isn't or is unrelated to salary, means it will be lack of equity. And the challenge 2 is risk pooling and the benefit package. I think firstly, from the risk pooling, the pool is based on the city. For the urban employee-based health insurance, the pool is based on city, and in the same cities, the pool will be separated by different group. For example, for the civil servant, employee in provincial-owned enterprise, or employee in city-owned enterprise will be at different pools. So the pool will be small. And for the urban resident health insurance, the pool is at city levels, and for NCMS, the pool is at the county levels. So the pool is much different between different city and different county. You know, the more people attend the program means the pool the pool is large. So the ability to risk pooling will increase.
So if it's a socially owned and managed fund, what does the concept of risk pooling at the level of the employee or the geographic region really mean? I mean, do they do employee group rated premiums, or
yes,
they do group rated premiums?
Yes.
So then,
but all of the pool managed by the social security systems.
But then, if the payroll tax is what pays for it, then there is no. I'm having difficulty understanding how that works.
I think for the urban employee health insurance, there are some subgroups. Right. One is for the civil, one is for the...
It's on the previous slide.
One is for the civil servant,
yeah.
and also, you know, from the Chinese economics, it was composed of the state-owned enterprise. The state-owned enterprise contribute more than, I think maybe more than 50% of the GDP, and others came from some we call it the collective-owned enterprise or the private enterprises. Mm-hmm. So this different kind of the enterprise in some area is different. The pool is different, but in Shanghai, the employee in provincial enterprise and employee in city-owned enterprise, the pool is the same. And in other cities, for example, in Zhejiang province, in Hangzhou cities, there will be 5 or 4 subgroup pools for the urban employee health insurance.
But when they pool, do they basically set their own premiums as well?
Sorry?
When they pool, I mean the risk pool basically means you take all health expenditures at the end of the year, you add it up, and that's what represents
Yes.
the total expenditures, right?
Yes.
So, but if it's based on payroll taxes, then how does that work?
The payroll tax?
Yeah, if the contributions are based on payroll taxes, then there is no real premium that you're looking at, right?
Yeah. You know, the Bureau of the Social Security get a foundation from the enterprise, and this money are the payroll tax, and then they can manage it individually. And for the employee prevention enterprise and in city-owned enterprise, there are no government subsidies. There are no general tax subsidies. Just for the civil servants, there are some government budget for as their premiums. And I also think that the benefit package is different in the different programs, and also there are some much difference between the regions. And most of the healthcare service in public health insurance purchased based on the fee-for-service. Fee-for-service may be related to the higher quality. However, it may result in the low efficiency. And there are some pilots on DRGS capitation on basic outpatient service, but there are lack of some evidence for the effect of this purchase method. And the third one is the regulation. I think, firstly, from the governance organization, the China lack of coordination of management of the different programs within the government. Ministry of Human Resources and Social Security is in charge of the urban public health insurance. However, in Ministry of Health is in charge of the NCMS in most regions. So, Ministry of Human Resources and the Social Security and the Ministry of Health are pursuing for the management of NCMS now. And from one side, China has strict regulation on the pricing, on the drug list, and so on. For example, the Chinese government made the price of most of the healthcare service and most of the drug, and the price is based on the cost. However, the government can't have enough energy to get the right cost, so the price, some of the price is much higher than the cost, and some of them is much lower than the cost. And also the price is unrelated to the value of the healthcare. In the other side, there are some loose regulations on some determinants. For example, there are no effective referral systems in China now. And it means that if you want to go to see a doctor, if I have a cold, I can go to tertiary hospitals to find a famous doctor to see me. And also there are little regulations of the public hospitals. So I make a very simple conclusion of the health reform, especially the public health insurance. We found that China has set up the framework of universal health insurance and have covered most of the Chinese. However, the big disparities in financing, risk pooling, and risk sharing across health insurance program, regions, and the type of enrolling. So this disparity will result in the disparity of the health. And the third one is ineffective regulations. So I think maybe the government will pay more attention on the following area. One is the financing method. Government should get more money through the multi-financing method. In the financing, government should pay more attention on the equity, financing equity. And also, the reform will pay attention on the reducing the benefit package difference across the program and the regions. Need the big pools. And the better regulations is also needed to in the effective referral system or the negotiating mechanism between hospitals and the health insurance fund. I think the most important thing in China is disparities. The disparity of the health status, the disparity of the healthcare utilization, the disparity of the healthcare health financing. These disparities was in the regions, was in the populations. So this disparity let me remember the mission of the Duke Global Health Institute. The mission, one of the mission of the Duke Global Health Institute is to cancel the disparity in community level or in the international worldwide. So I think maybe from one side the government should pay attention to decrease the disparities, and from the other side we can get some more evidence from the internationals. And I also want to give thanks to Lisa. She helped me to made this slide, and thanks to the Randy. He gave me very good suggestions. And I also want to say that, to be frankly, it's not a research. Today it's just a simple introduction with a very broad area. So I have conducted some programs related to the health financing, health security system, and the public hospitals reform. And also my colleagues are the member of the national evaluation for the health reforms. So if you are interested in the Chinese health reforms, don't hesitate to stop by me. I'm in the room 123.
Okay. Thank you.
And I'd also like to share some pictures. This is the Duke University and the Kunshan subgroupers kickoff pictures. It's interesting. I think maybe this one is on Duke.
Yes, that's our president.
Yeah, and
were
this.
You there?
Huh?
Were you there?
No. And these are pictures of the Duke sub-schools. Okay, thank you.
So we have time for some questions.
Oh, please.
I have a question about the different health insurance models, the compulsory versus voluntary, and one of the groups just had employees, and the other group had the unemployed housewives and children, I believe.
Yes.
And I was just wondering, has it always been set up like that the kind of women and children, assuming the women don't work and they're housewives, they haven't received the coverage in the same way within the urban split there?
Sorry?
Within the group of urban people insured, you have one group that's the people who are employed and the retirees are grouped together.
Yeah.
And the other group is if you're unemployed, you're a child, or you're a housewife.
Yeah.
And I was just wondering if it's always been divided in that way.
Yeah. Actually, the Chinese firstly launched the health insurance. the China firstly launched this program at the end of the last century, and then launched this program in rural area. So from the policies, people have job in cities can be covered by this one, and people living in rural area can be covered by this one. However, if the people haven't any job, or their children, or they are some self-employed, didn't attending in these programs, they have no health insurance. So the government launched another health insurance which will cover the rest of the population who didn't covered by the urban employee health insurance. So all of the people haven't covered by the urban employee health insurance, and they are living in the urban area, they can join this one. But the children and the housewife and the unemployed are the main resource. Please.
I know in the large urban areas, you have a large group of residents who are not permanent residents. For example, construction workers come from another part of China and work in Shanghai, Fudan, or Beijing. Do those non-permanent residents, do they have the same level of health insurance coverage, or do they have a different system?
I think actually this health insurance program is related to the informal sectors. If you're working in the informal sector enterprises, so the enterprise will buy the health insurance for you. But if you're working in the informal sectors, because the payroll rate is higher, and most of the payroll rate will come from the enterprises. So informal sectors, they don't willing to buy the health insurance for their employees. So if you have the job in the informal sectors, maybe you haven't get the health insurance. And also if you haven't the permanent jobbers, I think most of the permanent jobbers provide are from the formal sectors. So if you haven't the permanent jobbers and you are working in informal sectors, maybe you will be covered by this one. And actually, from the policies, these two programs are some overlaps. Please.
With the two voluntary programs, what % of the people who are eligible to be in the voluntary programs actually spend the money to purchase the insurance?
I think most of the people having a public health insurance are willing to buy these two programs. And I think that no public health insurance are people, they are self-employed, or they are employed in informal sector or in small sectors, or the people and all the people came from the rural area, maybe sometimes. But the people immigrate from the rural area to urban area, and so they didn't buy the NCMS, and after they go to the cities, they also can't covered by the resident health insurance. So I think it's very complicated in China because there are some population living in rural area, some population living in urban area, and some population working in the urban area, but they were population of the rural area. the population of we call it the floating worker. In China, every year there will be more than 200 million population is the population is the floating area. It means that in the beginning of the year, they leave from rural area to go to the urban area to find a job, and in the end of the year, they maybe come back to rural area, and in the next year, they will go to the urban area to find a new job too. So it's very complicated.
So just to follow up on that, if someone has gone to Shanghai, for example, from a rural area,
yeah,
and they have purchased the NCMS insurance, but while they're in Shanghai, they get sick and they go to a hospital, what happens?
It's a very good question. Now the administrator of the health insurance are facing this problem because some population leave their hometown, but their health insurance plan is on their hometown. So if their health insurance program doesn't contact to the, for example, to the Shanghai hospitals, they can't get any reimbursement. So that's why we should enlarge the pool, because if the pool is too lower, the pool will be limited to the local area. It can't be prolonged to other cities.
Any other questions? Okay. Thank you very much.
Thank you.